yourself so that I will start after Chitnis. We welcome to the district coordinator, Dr. and Dr. As I previously said, is but I definitely add on for those who require. The and director of the then in physical therapy I am at this moment we're very happy and proud to have Dr. Asha Chitnis Madam with us. So now, without taking much of your time, I request Dr. Asha Ma'am to start with her talk. Over to you, ma'am.
Thank you so much. A very good day to all of you, and thank you for being here and thank you for listening. What I'm really going to talk about today is the ICF, classification and goal setting in cerebral palsy. What really I'm going to cover is you understand these classification systems, use the ICF in the clinics, and understanding how do you really do goal setting, which is so important in our case. I guess heard Khushbu speak, and I also thank the IAP WC Satara webinar team, the National Health, and all the people that have put this seminar together, and also to all the stalwarts and mentors who wrote these classification systems. Everybody knows, but I'm just quickly going through these 2-3 slides, that we have to understand as therapists that cerebral palsy is, yes, a permanent disorder, but what really is very important for us is that it is the problem of movement and posture. And I guess we as therapists are all doctors of movement and postures. Because there is a problem of these movement postures, there is an activity limitation. Though this disorder is non-progressive, it will never ever say that CP does not have comorbidities. And there are problems with cognition, behavior, and epilepsy. Having said that, you need to also understand how do you classify that. Very, very important is you need to know what is the tone of the child. Does he have hypertonia, hypotonia? What are his functional abilities and what are his comorbidities? And also look at neurological elements. Not do we need them, but at least to understand them. And also look at anatomical distribution in the sense of quadriplegia, hemiplegia, tetraplegia. And then you need to also find out when you do what's the damage prenatal, postnatal, or perinatal. Very, very important. So if I just show you all this, this is a child who has one limb involved. This is tetraplegia, so his both legs and one hand is involved. He's somebody who's got diplegia, and he's someone who's got all 4 limbs and trunk involved. Hence, he's got quadriplegia. If you understand tone, this is dystonia. That is athetosis, where you really see too much of movement. When you see generalized hypotonia, this is hypotonia. And this is ataxia, where you see a child trying to perform activities but loses his balance and falls. This is hypotonia. You will always need to look at every kid that comes to you, what kind of tone and what kind of topographical classification the child has. Having said that, this is the most important thing. Every parent who comes to you is going to ask you how severe it is. Will my child ever walk? And who can answer these questions? When we talk about ICF, your classifications, and I'll explain you what motor growth curves are and how important they are for prognostication as we go further. Guys, you need to understand ICF is very important. It is called as International Classification of Function, Disability and Health. All these things before were not looking at function. It is in 2001 when WHO changed from the ICIDH model, and you have 100 names before that, but the focus shifted on the function, on the strengths rather than the disability. It has 3 domains and it is used for every age, and it is really very useful. And I'll, in the coming 2 slides, explain to you when a child comes to you, how to use it in the clinics. It can be used by multiple users. It is about the child and her world. That means participation, what the child does in society, not what he does at home or your clinics. I like it because it's common terminology and everybody uses the same across, because CP is a transdisciplinary approach. You can document them, you can set goals with them, and it can also use a measuring tool. Now, this part you know that is body function, you know it is activity, participation. These 5 things came out. Now, how do you put this into clinical practice? I'm going to explain this to you. Look at a child. This is a child with cerebral palsy. Body structures are all the problems or the impairments that you see. It could be a decreased range of motion. It could be spasticity. It could be strength of your muscle. Anything that happens at the physiological level is where these are your impairments. Because you have this, what it gets affected? It affects mobility, like sitting, standing. It affects your hands, so manipulation, in-hand manipulation. In all this, because they have this problem, it affects how you participate in society. Can you play? Can you go to school? Can you interact? Can you feed yourself in society? Guys, only this is not important. When you look and when you evaluate, don't forget the child. Is he a child who's very curious, determined, very strong, or is a child who's very cranky, very upset, fearful? And to add another dimension, who are his caregivers? What is the mother like, or whoever the person really involved in his therapy is like? What is his whole home setup? Very important when you plan your goals, because of follow through, and you need to understand them. If I further make it simple for you, I already explained to you this is muscle tone power. How do you test them? Basic modified Ashworth scale, manual muscle testing. Guys, when you use these scores, they are not outcome measures, they are the body structure level. If you're looking at mobility, you're going to use a basic PEDI and a GMFM. These are at your activity level. This cannot be used for research. What really comes out in research is your COPM. We'll discuss what is functional mobility scale, or there is a PEDI chat that tells you. So these are the differences that you need to understand. What scales use? If you're really looking at measurable goals, you really need outcome measures on your participation. Otherwise, you will have problems to kind of quantify. Having said that, I'm going to explain you every dimension. When I say body structure, you have to understand that it's already told you that it includes physiological functions, it includes anatomical parts of the body. It also looks at impairment. And remember, when we talk about impairments, primary impairment, which arises from the damage. You have a ventricular megallian, that is where you have a problem. That's your primary impairment. Kids with cerebral palsy always have primary impairment in the weakness system or the muscle strength system. But the deformities that you see is your secondary system, and that is because it interacts. There is a lot of issues that come together, and the problem is seen in the musculoskeletal system. What is a functional activity? When you look at a child, look at what all he can do. Can he sit? Can he play? Can he roll? Can he get? Can he eat? Can he get dressed? All this in your clinic means it is a functional activity. Then you have to say, can he not sit? Can he not play? Can he not walk? Or how he walks? So here you're understanding what is functional activity and limitation. Make your list that comes under the heading of gross motor. Then you're going to look at your participation. Just because he could sit in the house or he could sit in a car with support, can he sit in school? That is participation. Can he sit in a bus going home or going to a school? Can he sit with his friends in class? That is what it is. It is in the social context. Your goal setting also happens on the participation. It does not happen at the activity level. Every functional activity may not be a participation ability. Remember that. And participation restrictions are the things that he needs to do by his age in society and does not do them. And those are our real challenges, and those are our real goals that we have to look at as we go further. Participation, basically, if I have to just put it down, if for examples for you to understand, it can eat at a dinner table with family, can play with siblings on a floor at home, can walk to a lunchroom with classmates. And participation restrictions is can't carry his books to school or a bag to school, can't communicate his needs, he can't participate in the birthday party or can't climb schools. So this kind of should give you an idea. Just climbing steps is a functional activity, but the ability to climb steps in society is a participation. Hope these things make it clear to you. Number one, the other thing that you need to remember is your contextual factors affect your performance, and you have to look at those. One, our environment. Lots of our schools today don't have lifts and steps are there and our kids can't. So that's environmental factor. How do we as caregivers, are we really being can we just provide a ramp and so a child's wheelchair can go? Or what are the barriers? Does the mother need to carry him or a caregiver needs to carry him? And what are the extra concessions? So this needs to be studied in details. Very, very important when you form your goals. Very important. And also be very important to look at how much can you challenge a child. So hence knowing both a mother and the child, how much the personality matters, because if you have someone who's got poor cognition, who's very stubborn, then that's going to be a detrimental deterrent for us to form high functioning goals. So remember every aspect of ICF is so very important in your goal settings as we go there. Again, just to give you a perspective, any stiffnesses, decreased range of motion, a ribcage mobility, these are all your primary and secondary impairments. Because of this, they can't transition, they can't speak, they can't walk, they can't bite. But social participation is, again, I'm repeating this one more slide, is they can't play, they can't go to birthdays, they can't communicate. And contextual is stairs at home, no lifts, no ramps, and no rails at the bathroom at the malls. All these things come when you really look at that child in totality. So when you get a child, please look at every 5 domains of your ICF, and that's going to help you plan your goal. Coming to the second part of my lecture, which is the functional systems, guys. I'm telling you, ISCP, which is also a part of the Indian Academy of Cerebral Palsy, is going to make it compulsory eventually. You need to know what the functional classification systems are. You need to know what is ICF, because that's where you really help a child go further. So we have 5 classification systems, and I'm going to describe every one. So let's look at the first one. I've already shared with you all the PDFs. Please, when you get the time, read this PDF. They're very useful if you want to pursue your education in or continue your practice in pediatrics. It comes from canchild.org, from Canada. The functional classification system is not an outcome measure. It is a classification system, and it helps you when you're doing research in your inclusion-exclusion criteria. It talks about meaningful daily activities in all the domains of you walk, what is mobility outside. And I tell you, we go further, if you're really going to look at in general one, and level 1 is like me, there are no limitations. Level 2 is it walks with limitations. That means it's going to require a crutch or some support in society. Level 3 is he always going to be dependent on any mobility device. Today it could be a crutch, a walker, or eventually a wheelchair. And level 4 and level 5 are absolutely totally dependent. They need to be categorized. A very important point to note, if you do early interventions and if you're looking at kids between 0 to 2 years, please do not categorize them. You start categorize them or classifying them between your 2nd to 4th birthday, 4th to 6th birthday, 6 to 12 birthday, and 12 to 18 birthdays. This whole PDF that I've given you has everything. What I just want to bring out in one of the slides, look at the different levels. Once you get a child and if you say, oh my God, he's doing everything at level 1, see that can he floor sit, can he transition to pull to stand, or can he use any mobility, or is he someone who can't? Can you look at this difference? This difference will tell you at what level. So you have a general classification, but then when you look at his age, look at these which are given in that PDF. For every it is given 4 to 8, 4 to 6. What I like is this picture. I'm going to go to the second picture, which is very clear, and I'll explain you. Look, this is at 12 to 18. Level 1 is independent throughout. He doesn't or will never ever require any support. Look, level 2. If he's climbing steps as he grows older, or if he's walking in society, he may require crutches. But remember, level 3 starts with a walker. Suppose this child is smart and in an university or doing IIM, who's a diplegic, or he's on a holiday, he will require a wheelchair, maybe a motorized one, but he will require because he will not have the endurance and he will not be able to participate well in society. Versus if you look at these two groups, they're always going to be basically what I should say dependent on wheelchair. They may take 2 steps to wheelchair the level that doesn't mean they are okay. I would just put this picture in your clinics if you're practicing, because this is really going to help parents see it, and then the parents will say, oh my God, this is where my child is. Don't you think so? So setting a dialogue with a parent also becomes very, very easy. Helps people see where their own children are. It helps a parent understand, and it adds to their perspective, and it gives them an empower them. Now look at this. These are some videos. This is level 1. She's 12 to 18. She can walk as and comes down, doesn't require any support at this point of time. If you start looking at the other videos, you see how they're all playing together. She's also level 1, but level 2, you see how much support she requires to climb up and down in community. So this is how you will look every child that comes to you in society. What does that child do and what are the functions he needs to do? Look at level 3, see how much support she requires to climb it. Let's see that she's going to school. This is what she's going to require. Or somebody may do very well with cord canes, come out of a lift and then walk to the how do I say, the corridor of her school. But that is what I'm saying, that they will require handheld mobility device. So this is GMFCS 3. Now let's look at GMFCS 4. Now look at her. She's crawling between 2 to 4 years. She needs all the, she does maintain her head, but she is GMFCS 4. This is a child in school, requires 2 people to guide him towards his dining table in school to eat his box. Versus a 5 requires all the support to dress and to be carried. Now this is a young child sitting in school, but see, this child has all kind of proper chair, proper support to communicate in society. He would have not done it if I would have not given him this adjuncts. And this is how they kind of participate in society. Now, when you come down, this is very, very important. This is something that will help you prognosticate, and I'll explain you. These are called motor growth curve chart. This is a lovely research that has been done by the group from canchild.org. You can find there. They're a group. What they did was they looked at some 600-700 kids from a state, Ontario in Canada, and see what they came across. They really came across something that is so good. And just look at these basic lines. Remember, sorry, I'm just going to go back here. These basically is, remember, GMFM 66 is a computerized, excuse me, outcome measure. You can use it. You need anything that is going to be plotted here. You basically need a GMFM 66 or 88, which is computerized, not a plain GMFM score that you can download. You can't plot a graph. And these are your ages. Look at how they go. And now I'm going to go ahead and talk to you. This is very important. Look, remember the one in the red is level 1. They will always do well, and that's the picture. Look at level 2. That's the picture. They will continue. But your level 3, level 4, and level 5, this age is very important. The ages between 6 and 13 to 12, actually, when you have proboscity, when you have hormones, when you have puberty that is coming, when you will have growth that is happening, the focus from good physio will start to schools, other interactions. All is the time when you start seeing that decline. Also, a very important point to note, once you classify your child at 2 years, that is the GMFCS 1 or a 4, it does not change. What I'm trying to tell you is 1 will remain 1, 2 will remain 2. A 3 can never become a 2, or 2 can never become 1. But because of this study, a 3 can go down to a 4, a 4 can easily go down to a 5. Even a 2 can come down to a 3. You have to understand that classification systems never change after 2 years throughout their lifespan. Another very important point, if you ever have any lectures on neuroplasticity, this is a work from Karen Pape, and see what she says. You have maximum neuroplasticity happening in the first 4 or 5 years. Then there is a dip in the same 6 to 12 years here. and then again it takes off. So do you realize how important goal setting is between these 6 to 12 years? If you're really not vigilant, knowing this, the child can literally go down. So I feel it's very important to understand what you need to do when you are approaching this age, rather prior, pre-necessities, very, very important. So what it really also tells you, it's very important. What I like about this is it describes the gross motor function. It estimates child's future. Also, a child in GMFCS level 1, 3, or 4 will remain in the same level throughout his life or go down. Guys, one more point to understand. Any kind of therapy you do, you may do Botox, you may do intrathecal baclofen pumps, you may do surgical interventions. They may get him a better quality of life. But if you're asking me that he's going to, so the parents ask me, oh, now he's operated, he's going to walk independently. The answer is no. A child who's got a GMFCS3 will walk much better, maybe faster, take more steps, but a walker or a stick may never go away. So that is something that you need to counsel your parents. And that is something, that is why I like this, because everybody speaks the same language. If your orthopedic surgeon says he's 3, he's going to be 3, he can never become a 2. That is something that is very, very important to understand. I like this. Something that I always come and talk to parents with therapy or any other special investigations. How bad it is, GMFCS will tell you. Will our child walk? These motor growths will tell you. And how do you know therapy is working? Use these scores or any other outcome measures that will measure time for change. I really like this. This basically is good for us, but for these two things are very, very important. And once you, the first points are very important. Again, orthopedic surgery, having the same language gives you an advantage and doesn't really mess up and parents empowered. Now coming down to FMS, that is functional mobility scale. I'll give you that also. This is something which is very good. I like this scale. It comes from the group from Melbourne, from Professor Paul Graham. But this is an outcome measure. This was devised when kids were undergoing surgery. Why is it? I like it because what it talks about is you're looking at a child. So basically, you only use it for level 1, 2, 3, 4, 5. Really, you don't use them because it just does not help. Why you're evaluating? Anybody who can walk with any crutches, not crutches, walker, whatever. Can he do 5 meters? Can he do 50 meters? And can he do 500 meters? 5 meters is home, 50 meters is school, and 500 meters is outside. It's totally reverse if you really see. Of the GMFCS, level 1, which was independent, is totally dependent on a wheelchair. Level 2 basically is another, he'll always walk but with support. Level 3 is again walk with crutches but with support. So these are like your 4s and 5s. Level 4 here, basically walking independent. Level 5 can walk on any surfaces and 6 can run. So you are going to evaluate, can the child, a 6-6-6 score means he can do everything. But somewhere you may have a child who's doing 6 at home, a 3 at school, and maybe 1 maybe at society. So you're really going to look at all these things for 3 given dimensions. You can't just do it for school or home. You do the same child and see for 5 meters, 50 meters, and 500 meters where he is. It's great. It's used for all patients undergoing surgery, multiple surgeries. And these are the kids that this whole functional outcome measure came out. MAC is basically looking at use of hand. There are 2 MACs. A mini MAC is something that you use from 0 to 4 years, and the other one is from 4 to 18 years. It's beautiful. When you have a child with hemiplegia, you would say that one side is normal, but the other side you would put the MAC. What you really are looking at is how do you handle objects of day-to-day activities. How does he eat? How does he play? How does he kind of write? How does he bathe? All the using his hands. And does he need any support or adaptation? So this is also very nice. It says it's more or less so parallel in every classification system. There are enough research, enough reliability and validity has been done. So it's very easy to accept and look at it. Now, level 1 talks about handling the objects easily and successfully. Here you're talking about you do handle the objects, but you require more time. So less speed. 3 will require all adaptations. 4 and 5 are somebody who is actually going to require a lot of support. So that's what's going to happen. Now, if you really go and look at them, look at level 1. She can sit and write everything. She's independent. Now, this is a child who's opening a bottle, does require time. We need to give him the time. If you give him enough time, he can absolutely operate. If you look at the third, level 3, see, he's been given the t-shirt, he can wear it. But if he had to use his own t-shirt, it's very difficult. This is a child writing, and he has got a pencil aid, and that is where he writes. But if you just give him a crayon, he's not going to write. And someone who's level 5, basically is trying to tell that, okay, hold my hand, I'm going to, you help me, and I am definitely going to look at cutting it and using it. So that's how she's doing it. So this helps you understand where your child is. And you could have a child with hemiplegia or tetraplegia where one hand can be normal. Please put it down in your thing that one is one, MAC 1, the other is wherever you're going to classify that child. Great. I mean, I already told you that it's really good to really classify. And I think so one more point when we discuss goals, you should understand when you have anybody who's at that levels of 3, 4, and 5, please don't look at handwriting. Don't look at eating. That hand is always going to be a supportive hand. Now, communication classification systems basically talks about not how do you speak, how do you communicate. So a non-verbal child can also be classified here, and it's very important. So I'm going to explain to you, these are 3 things. This is a person with cerebral palsy, unfamiliar person, and a familiar person. So level 1, he can talk with anybody at any given time, speed, anything. Level 2, he needs more time. He needs more time with unfamiliar. Familiar, family, caregivers, therapist, he's fine. He can communicate. Level 3, he may require some kind of augmentative communication, maybe. May require a picture exchange book. I'll show you what it is in the next slide. But it's going to require enough time both with familiar and unfamiliar people. Versus 4, absolutely lots of time with not unfamiliar but only familiar people. 5, you really need to understand what the child is saying. So for unfamiliar people, level 4 and level 5 is very, very difficult. So I feel if you guys are really taking care of your children, by 1 year, start getting a picture exchange. Yes, no, and I'll show you what I mean. So now he's talking. See, they're level 1 taking part in a play, doing so well. They can manage, they can communicate, they can tell, they can speak. Look at level 2. He's starting in the garden or going to a store, and he can manage it. No problems. But look at level 3, 4, and 5. Level 3 can talk to own caregiver. He can talk. Just talk to them. Level 4 and level 5 are non-verbal. Exchange. So she's asking, I take the hand and support her and make it yes and no. Similarly, this helps teachers, helps us to know the book made the papers when you want to eat. Are you in pain? Are you happy? Are you not happy? You always make that, and please empower your parents to teach this, because if you use it in day-to-day practice, this is going to be of great importance to you. The last classification system is about EDAC. It's very, very important because this is where you're really going to look at your swallowing. Never did early intervention, your swallow breathing comes by 2 weeks. This is talking about eating, drinking, and ability classification systems. Level 1, they independently eat and drink safely and efficiently, no problems. Level 2 also they can do it, but with more time and less efficiency. But level 3, level 4, and level 5, I please talk to your feeding therapist, see this swallowing, and look at what kind of textures, what spoons you use. Do you use the feeder? What is it? Because this is how it gets more limited and limited. And the reason these things are very important is they can have aspirations, choking, and a lot of pneumonia. And another thing that is very important is if you see these kids struggling to eat, they'll never put on weight, which is very important for normal growth and cognitive development. So I always believe, talk to the doctors, talk to the parents. And these are kids, specifically the 4 and 5s are the kids who may require a G-tube or a peg stomach for feeding for a few years before you can really work on swallowing and not have the dangers of choking. And always remember, a child, however involved, will always take care of their airway. They will position their body in such a way that nobody can mess up with their airway. To that extent, sometimes they will say no. So be very, very vigilant, and this is a very, very important functional classification system. Please write it down when you are evaluating your child. I guess the last part that I'm going to talk about now is goal settings, but I feel what I'm summarizing is every classification system is so important. It classifies the child. Functional gives you the limitation, tells you the ambulatory abilities, tells you how you need to communicate, and also tells you how is eating habits, following. So it's a great tool. I feel it's important for every therapist doing pediatrics. These new tools are coming out different for kids with autism and sensory kids. They are not yet out, but these are only for kids who have a neuromotor disorder, and more so with like epilepsy, encephalitis, and traumatic brain injuries, anything under the banner of CP. Now, how do we decide goals across a lifespan? What I mean by goals, you need all this. I asked you a question which I saw your whole. I liked everybody. I think everybody for answering those 5 questions. And I feel SMART goal comes from the study of Margaret Maston, and she says SMART stands for specific, measurable, A for achievable, realistic, and time. So any goal setting that you do has to be very specific to that child. Please consider this when you're doing goal setting. You need to challenge it, not challenge it in such a way that overwhelming to a child. It can be measured. That is what I meant. It can't be overwhelming, so it is achievable, very realistic to the child. Do not send writing for a child with hemiplegia who's math 3, and time, very important. So now I'm going to talk about what you do is, if you really look at the classification systems, go step by step, look at it. If you're looking at a child, for example, at level 1, I am going to really look at somebody who I will work on cruising and transitions in my goal setting. Your goals have to be functional. They have to be made. I'll talk about a proper goal later on, but just understand this. But if you have somebody who's level 4 and 5, you can't plan a goal like cruising and transitioning. You will have to say support. Your support is very important. These 2 people will function without support, but these kids will not function without support. And they're going to really require support throughout their lifespan. Again, between 2nd and 4th birthday, it's the same. They may play a ball, walk to a mom who are 1 and 2. But otherwise, they are going to really need a lot of support for 4 and 5. So please, classification is very important. I'm going to bring out one more point. I also use MAC here. Suppose you have a child who's got quadriplegia. Look at which hand is good, which hand can function, and what hand can be assisted. If you have a hand which has hemiplegia, look at the good hand and the so-called involved hand, and then plan what you would want as far as handwriting, eating, ADLs, all these activities. Same for 4 to 6. I tell you, the moment I would suggest here, remember, between 2nd and 4th, work a lot on transitions. Get transitions, don't make them get into in transitions, but work towards transitions. The more you work towards transitions, this phase and the coming phases are good. So parents who are very involved, specifically the 4s and 5s, if you at least show them hand and a pivot transfer, that's going to help the parents so much for putting them in a wheelchair, getting them out of the bed, getting them to the bathroom, getting them out of the bathroom, or going for a bath. So transitions from 2 years to 18 years, do not forget, very, very important skill, specifically for the 3, 4, and 5. 1 and 2 will just transition. They will not have any problems. It's the 3, 4, 5 will have max assist, and they will require lots of problems. 12 and 8, again, it goes the same. Look at 1, he walks outdoors. So that's where you're going to look at play, something like a basketball or a football. But here you can really look at someone who can do a stair climbing. But for 3 and 4, you're really going to look at, can some 3 propel a wheelchair? Can he use his hand is good? Can he literally use a motorized wheelchair? Makes his life easy. Can he transition everywhere? And 4 and 5 will be supported a lot. You have to always look at affordances in the environment too. The same for 12 to 18, that applies across a lifespan. So this should basically help you do goal settings. I'm going to take one case study before I end. Now look at him, just watch. I'm giving you, it's a minute video, have a look at it. And then you see, I'm going to go that this is, I'm showing you all, because this is how I'll tell you his ICF, and I'll tell you what his goals, OTPT speech goal should be. I'm showing everything that he does. Just follow this video. See how he's transitioning. Keep a look, because I'm going to tell you his ICF. Just have a look at this video. See how he walks. See how he stands. And lastly, see how he walks. Before we really do his ICF. See how he walks outside. So now, if you really look at his ICF, look, he's someone who's a GMFCS3 at this age. He's an 8-year-old child with CP. He's got quadriplegia. He ambulates with a walker independently for moderate distance. He can stand next to furniture or walk with arm support. He can transition, you saw from Brent, these become functional activities. He can transfer objects. He can release, grasp an object. He finger feeds. He assists with ADL, and he communicates verbally. What he can't do, does not ambulate without assistive devices, does not climb stairs independently, does not stand independently. He can't sustain a lot, and he not only sustain standing, he can't even stand, and his pitch and rhythm, his endurance is so bad that if he has to recite a poem, that is a problem. And he doesn't have a great grasp the way you need to write. So if you really look at his participation, he is able to participate in school independently, ambulating within the classroom and with using a walker, but able to participate with siblings in outdoor play using a walker. But independent play in standing, walking is not there. He can't ambulate and go out with friends in long distance. He requires huge assistance for climbing steps and curbs, and he has difficulty making needs known in group environments. So if I have to really plan his goals, look at my PT goal. Aditya will walk 20 steps with cord canes, one hand held, and go to school. Means you can either have one hand held the way I showed you, or take cord canes and give him a lot of time to go to the school, from the school gate to the class with good alignment, and give him that time frame for 2 minutes. If you're looking at an OT goal, he will doff his shirt using bilateral upper extremities when seated on a bench with dynamic, means when his foot is forming the base of support and maintaining that. So he can at least doff, remove that shirt from here. And if he is if I'm the speech therapist, Aditya will utter 4 to 5 words, phrases in class with appropriate level of loudness while seated or while standing on a table with good alignment. So this basically are what goals you need to form. I never said he'll walk independently. I never said he'll draw anything. I never said that he's going to have conversations. So I feel this is very, very important. So classification systems with realistic goal setting in cerebral palsy is very important. He helps, I mean, I feel always look at participation according to ICF and always have SMART goals. So I think so with this, I'll not go further. I end my lecture and I'm open to all questions. And I feel like before I end, I need to thank all my colleagues, mentors of OT special speech, and all the families and the children that I have been privileged to work. Thank you so much for your patient hearing. I'm all open to questions.
Thank you so much, ma'am. It was a wonderful talk. We have a few questions in our chat box. I request members and all the participants, those who have any questions, kindly post in the chat box. We have a question answer session which will be held by Dr. Trupti. Over to you, Trupti.
Can I just stop sharing? Can I stop sharing the screen so we can discuss?
Okay, ma'am, no problem. Good afternoon, one and all.
Ask the question. Yeah, ask question.
Thank you, ma'am, for such a nice presentation. It was indeed a great presentation. We have a few questions here for you, ma'am. The first question is max used? Yeah. Is max used for overall function of hand, or do we use it for affected hand only?
My answer to this is, remember, MAC is a classification system. Again, I'm saying it's not out. You only look at hand. So if you have a problem with the hand, it will classify you. And then if you want to have an outcome measure, you can use Quest, you can use Copum, you can use PEDI. But this is not an outcome measure, but it helps you classify your child. Absolutely.
Okay, ma'am. I think the answer is clear to everyone. The next question is, for SMART goal, do we need to use all the classification systems, that is ICF, MAX, GFF, GMFMC?
Yeah. For any goal setting with children with cerebral palsy, first look at age. Is he 0 to 2, then you need to really make goals as per the levels. But once he has crossed 2, it will give you an idea what that child is going to do. So what, I'll give you an example. I don't want at 6 years someone saying, I want to make him walk independently when his GMFCS classification is 3. He's never going to whack. The moment you tell him to take 4 or 5 independent steps, you're teaching him lots of wrong compensations, which can also lead to so many other secondary muscular problems. Always classify the child, look at where he is, and then set your goal. It has to be participation. Don't tell me he walks 4 steps in the house, so he's going to walk in society. Not happening. It's totally a different ball game.
Okay, ma'am. Thank you. And the next question is it so that the therapy helps child to improve within the level of GMFCS and not bring them level down?
Yes, therapy is extremely important. You need to be very smart to plan therapy. And the biggest window is 6 to 13 years. Okay, that is where the decline starts happening for levels 3, 4, 5. And remember, the biggest challenge is growth, obesity, puberty, and hormones. I think so that is our biggest challenge. So it's better to maintain them. Even if you don't gain much, I'm happy if you just keep that child there. It's extremely important.
Okay, ma'am. Ma'am, the next question is how to balance between functional independence and avoiding disuse of affected side?
When you describe functional independence, I think so you need to understand if that question, that number one is, first you need to see who the child is. Is he a child with diplegia or is a child with hemiplegia? Then I can talk about functional non-use, as you say. Then you have to really see, remember that when you're looking at a child, for example, with hemiplegia, your right hand is going to be, let's say, it's child with left hemi, means left, not hemi, left side involved. Your right hand is going to be the dominant hand and your left hand always is going to be an assistive hand. So you have to plan accordingly. If you have a child with diplegia, I have a word of caution, guys, here. Please select a good mobility device, because I do not like elbow crutches, because elbow crutches will take away the so-called good upper extremities with so much of internal rotation. I would prefer that they are given cord canes with good support or a walker. So that is a nice way to look at it, and also be very realistic with the parents of what the child will be able to do and what the child will not be able to do.
Okay, ma'am. Ma'am, the next question is there any separate scale or classification system for assessing patients with dystonia?
There is a scale which is called BAD. It's called the Barry Albright scale of dystonia.
Okay. Ma'am, the next question is, in goal setting, can you please explain about timed measure?
Timed means, you saw how I went and explained to you that he will walk from XYZ to this in 2 minutes. So there is always see, when you do goal settings, you'll always do a pre-test. That is why the smarts achievable. So you have to really time it. You can't give it 5 minutes for a small distance. That's where so that will tell you that, oh my God, have I worked on his endurance? Have I worked on his speed? Have I worked on these things in a given time? So that's very, very important.
Okay, ma'am. Ma'am, how to balance between functional independence and avoiding disuse of affected side?
I just finished that question, my girl.
Okay, ma'am, it's repeating. I'll just go to the next question.
Yeah.
Ma'am, can physios expect any change in classification system at long period follow-up visits?
Never. No, never. Never. Classification systems don't change after 2 years of age. And I tell you one more thing, guys. By 1 year, you will know where he's classified as. But you will not give him a label. By 1 year, if there is no head holding, he's definitely going to be a 4 or a 5. You just don't give that, but you can change a classification. What you can change by therapy is the quality of his improvement and prevention of secondary impairments.
Okay, ma'am. Ma'am, another question is, SMART goal should be always based on results of all the scales?
SMART goal should be first based on your classification, where he can go on the participation, and then see, outcome measures or scales are used to measure improvement. Look at him totality, see everything, and then do it. Yes, absolutely. But remember, guys, lots of these outcome measures, outcome measures are basically, how do I say, paid outcome measures. Okay, guys? Hello?
Yes, ma'am. Ma'am, the last question, we'll stop with the question session. Ma'am shall answer it afterwards. So the last question is, how to categorize a child having sensory issues?
Wow, that's a lovely question. That's a whole ball game by itself. But yes, I'll tell you, it's a different lecture by itself. But guys, remember, you have to look at 2 things. Our kids will have 2 problems. One, a motor deficit, and one, a sensory processing dysfunction. Now, when you evaluate, you will see that a child cannot walk because his primary impairment is the sensory system, or his primary impairment is the motor system. So I say sensory-based motor dysfunction or motor-based sensory dysfunction means a child with cerebral palsy walks with lateral flexion. We have to understand that we need to take care of the sensory systems, because these sensory systems are such systems which will be affected because of default. Versus a child with autism or a child who has got lots and lots of sensory issues in cerebral palsy, you need to also understand that it does not sit well because I feel that his sensory systems do not work. Hence, it's the sensory systems deriving the motor systems. That should be your first eval done. What drives what, and then you can really treat.
Okay, ma'am. Ma'am, thank you very much for answering the majority of the questions. I hand over to Dr. Khushbu for the vote of thanks.
Okay. So it was a lovely question answer. It was a lovely. Yes. Thank you. Thank you so much. It was a lovely question answer session. It was a lovely question answer session. Those who have missed their question, those who have missed the questions, what we can do is you can post your questions in the WhatsApp group. So please go ahead and do that because we do not want to miss on any of the questions. So and also I would put on few links in the chat box as well as in the WhatsApp group. Those links would be the post MCQ questionnaire and the feedback form. So I request all participants to fill that. Before we conclude, I should thank all of you, all the participants who have shown so much of enthusiasm and gathered here in large numbers. I can always say it was a houseful session, and extremely sorry for those whom we could not accommodate in this session. Very thankful to the speaker, Dr. Asha, to have spared the valuable time and agreed to share knowledge with us. Also grateful to Dr. Suvarna ma'am for being a strong pillar of support and immense guidance throughout the course of this event. I'm also thankful to Dr. Pooja, Dr. Snehal, Dr. Uttara, Dr. Nirali, Dr. Priya for being there all throughout the organization of this webinar. Thankful to the National Head, Dr. Ruchi, and IIP President Executive, Dr. Sanjeev Jha, for motivating us in organizing the webinar. Lastly, thank you to all who have been involved directly or indirectly in making this event a great success. Before concluding, I again repeat, all the participants, please fill the feedback form and the MCQ questionnaire. And yes, the questions will also be answered in the WhatsApp section. Thank you all once again. Stay safe.
Thank you guys for inviting me. And I'm just taking this opportunity. Can I just put a survey in your group, which is we are coming up with the National Hip Surveillance Guidelines. Since we are all therapists, may I just put that, and I would request everybody to do that. Is that okay with you guys?
Yes, ma'am, definitely. We have Bye. Thank you, ma'am.